Super excited to have Dr. Steve Bakir, an interventional cardiologist with Cullman Regional, here on the podcast today. Today, we're talking a little bit about minimally invasive treatment for cardiac disease. Can you explain a little bit about what an interventional cardiologist does and how maybe it's different than a general cardiologist?
A general cardiologist is somebody who's done an internal medicine residency and then done specialized treatment or specialized training in cardiology or cardiovascular diseases. And so they're treating a broad array of cardiovascular disease, be it hypertension, heart failure, atrial fibrillation, coronary artery disease. They're really treating the gamut of it. An interventional cardiologist is somebody who's a general cardiologist who's done a little bit more training in being, for lack of a better term, a plumber. So, an interventional cardiologist is somebody who does stenting, balloon type procedures where we open an artery from outside of the chest, meaning going in through the groin or the wrist. And in interventional cardiology, we're broadening that. So, treating heart valve disease and moving into treating placing a new heart valve or doing heart valve repairs, all from outside the chest.
And so, and it kind of rolls into the conversation of minimally invasive. I think people
Right.
hear that term thrown around sometimes in a variety of different maybe specialties. And so, um, you mentioned a little bit of some of the ways it kind of looks at it from the cardiologist perspective. Is there any other sort of like within that minimally invasive subject that you would want kind of people to know about from the cardiology perspective?
Sure. Most people think about treatment for cardiovascular disease beyond medications and lifestyle modification, which are still mainstays of therapy. We do enormous amounts with medications and lifestyle modification that really help us live longer and stay functional till later in life. Um, for those of us that are more on the invasive side, for patients who are in the middle of a heart attack, or for patients who have a mechanical problem with a heart valve, um, interventions call to mind everything from a balloon and stent, which most people are familiar with, to traditional open heart surgery, which is several days in the hospital and an open chest type procedure. Over the past 20 years, we've made great advances in how to avoid those more invasive procedures and how to address heart valve disease and coronary artery disease without opening the chest. So, cardiothoracic surgeons can go in through small incisions in the chest or robotic approaches with just a couple of ports and do a full open heart surgery where they put the patient on the heart lung machine, stop the heart, and are able to repair or replace a heart valve or even do certain bypass operations from limited incisions. I'm not a cardiothoracic surgeon, I'm an interventional cardiologist, and so what I do, which merges with what
Mhm.
they do to a great deal more than it was, say, 20, 30 years ago, but what we do as interventional cardiologists is we can take a heart valve and mount it on an IV that's roughly about the size of the ballpoint pen.
Mm.
I don't have one here, but and then that goes into a leg artery, and you can deploy a heart valve inside a beating heart. Oftentimes, the patients aren't even under general anesthesia. They're
Wow.
sleeping, but not on a breathing machine. And so, um, my grandfather, when he was in his 80s, had an open heart surgery to replace his aortic valve. Nowadays, somebody in their 80s, it'd be almost unheard of to have an open chest procedure to replace an aortic valve. We would go in and do that through a leg artery. And when it works out well, and most of them do, nothing is risk free, but when it works out well, you could go home the next day with a band aid on your leg.
Wow.
And a brand new heart valve functioning. So, minimally invasive interventions for treatment of heart disease is a broad spectrum, uh, mm, starting at the end of a minimally invasive heart surgery with a true heart surgeon, and then moving on to the other side of treating heart valves through the leg veins or arteries, which we're rapidly expanding that treatment options for us.
Yeah, and so what does that sort of the evaluation process look like for patients that come in to see you and kind of finding that best fit for them? Because you said it is such a broad potential spectrum of the surgeries themselves, there's, variety of different specialists that have a variety of different expertise. What does that look like for you specifically in kind of evaluating that particular patient to see that they're the best fit for something like that?
Well, I think, you start with your internist, you start with your primary care provider, and you talk with them about symptoms. And if you're having symptoms, shortness of breath, chest pain, passing out, heart racing, then oftentimes those patients are shunted towards a cardiologist. And in my role as a general cardiologist, I'll see patients of all sorts in the office. And then if it looks like those patients have a more specific problem that might lead to an intervention or maybe need a diagnostic procedure. For cardiology, we barely think these days. We could barely say hello to you without doing an ultrasound or an echocardiogram. Um, but once we have an idea of what the general problem is, oftentimes they might be seen by an interventional cardiologist. Maybe you're referred to by your general cardiologist. Um, for a diagnostic procedure like a heart catheterization. And then after we do the diagnostic procedures, what we would recommend will depend on what we see there.
Mm.
And so here at Cullman, we do diagnostic cardiac procedures, cardiac catheterizations, which they've done here for a long time. And then to varying degrees have done certain interventional treatments, uh, opening leg arteries, opening visceral arteries, and at times opening cardiac arteries right here at Cullman Regional for with balloon and stenting. So, you'd start that process with your internist and with your general cardiologist, and then move to a plumber like me
Mm.
if it looks like we need to do something.
Yeah, and it's pretty impressive, and it's incredible just to even think about that some of those surgeries that you're doing, have that ability to have, it's a Band-Aid and they get to go home and they get to have that the success rate that, once would have been, days, weeks, months of recovery. Um, that patient goes home from a surgery from you. What is that maybe their lifestyle look like, the changes that they would have to do or experience? Or is it a pretty quick, I mean, obviously it's a quick outpatient, like getting them home process, but what does that actually look like from then? Hey, they're home, they have this thing, they've done the plumbing now. What does it look like now from a recovery perspective and a lifestyle perspective for those patients?
Of course, that varies to some degree. Oftentimes, we're doing these procedures in patients who are older, who perhaps have had problems for a long time
Mm.
and have curtailed their activities. So they're deconditioned. And so once we intervene, once fix a mitral valve, or once I replace an aortic valve, or open an artery with a stent, um, then that might correct that plumbing issue. That doesn't mean that the patient is, ready to run the 440, or, ready to do the next 5K with their local charity. It might mean that they need conditioning. Cardiac rehab is a mainstay of these procedures because it often takes a little conditioning to get the benefit
Mm.
of the procedure. I mean, that being said, somebody who has severe aortic valve stenosis, the aortic valve is not opening. It's like a rusty door hinge. And so if we replace it, and all of a sudden you have a new aortic valve billowing open like a sail on a sailboat, then those people might feel better the day of the procedure. And certainly if they're walking around, you can have some pretty dramatic results early on. Not everybody. We always have
Yeah,
to show
every patient's
those.
a little bit different for sure.
And those are the people that'll make the commercials. But that not everybody pops feels like they're 25 again that quickly. Um, but most people have significant symptomatic improvements relatively soon after the procedure. Whereas the more invasive the correction is, the more you have to recover from the correction, especially if it's an open heart surgery. It takes a little while longer to even get from the where you want to go from the bedroom to the kitchen to get a drink. Um, and so it takes them longer to realize the benefit of the intervention.
Yeah, and so the typical demographic of the patients you work with are in that maybe post-retirement age. Or do you see or d is it have you seen cases or do you see on often where you do have, a wide assortment of age ranges and demographic that is best fit for it, and it's just a patient-to-patient, consultation to figure out, if it's a good fit or not?
So there's a lot of individual decisions that come with this. If we're replacing a heart valve, especially doing it from a minimally invasive point of view, we're often replacing it with another bioprosthetic valve, meaning made from the tissue of either a cow or a pig's heart. Um, and so that tissue will degrade just like the native tissue. It's not a one and done fix. So if somebody young like yourself needed a heart valve problem, or had a heart valve problem and needed a replacement, we would gravitate towards the more toward the mechanical valve. Um, Whereas most of my patients are older, most of them are after retirement, not all, and particularly with this set of risk factors that we have that are very common here in Alabama. Those of us who are there's a little more of us to love than there ought to be. People who are smokers, we see cardiac disease, cardiovascular disease in a younger subset of people. But for the most part, heart valve disease and for the most part, vascular disease is a disease as we get into our 40s, 50s,
Mm.
and older.
Yeah, and so, as we kinda wrap up the conversation, what's sort of the most important thing that you'd want someone to know when it comes to early detection of heart disease?
I think being really mindful of your body, and if you're not able to do what you've typically been able to do, those are the times when we would want you to come in early. I'm not saying be a card-toting hypochondriac, but if you notice that you used to be able to walk to the stadium and to your seat um, last year, and all of a sudden you've got to stop a couple of times on the way, that's probably something that needs to be looked into. So if your exercise capacity drops off, if you're having new symptoms of shortness of breath, chest pain, certainly if you're having anything dramatic like passing out or heart racing, those are things to get into your provider, whoever it is, and talk to them early and make sure that they take it seriously, and then we'll go from there.
Yeah, well, I appreciate you taking the time. I think, often our conversations on the podcast, it is about, just being aware of yourself and being aware of your body and not putting necessarily those things to the side. I think it all often comes back to having that general doctor, that general practitioner that sees you on a regular basis, someone that can see that year over year changes that you maybe don't see for yourself. But I appreciate you being here. We'll have everything in the episode notes and information. So if anyone wants to find out more, get connected or anything like that, they can visit the show notes. But I appreciate it.
Appreciate you having me.